Welcome, everybody. This is Optometric Education Consultants National Webinar Series, Tuesday night edition. It's our great pleasure to invite an outside speaker, Dr. Michael S. Cooper. Coop to his friends, you can all call him Dr. Cooper. And he is an optometrist and president of Visionary Medical Education, which is launched to drive change in education by improving care for patients by enhancing clinical competencies of the collaborative ophthalmic care team. He is past director of professional strategy at Kala Pharmaceuticals and co-founder of the Intrepid Eye Society. He specializes in complex anterior segment infectious disease management, where he's treated a variety of conditions, including dry eye, external lid disease, allergy, and uveitis. He has been published in numerous journals. He has been actively involved in global clinical studies for novel anti-infective therapeutics, evaluating the efficacy of meibomian gland treatment modalities, doing retrospective analysis of the glaucoma medication efficacy and safety, and AMD genetic research. And I think it's very honorable and very noteworthy. We do pay honorarium to our speakers, but Coop has foregone it, and they asked us that we donate it to a charity. And a charity that OEC has worked with is the Phoenix Children's Hospital, Homeless Youth Outreach. They work in human trafficking and support human trafficking victims. We've made many donations. So, Coop, that's where your money is going to be going. And we thank you for your time and expertise. If you want to put on presentation mode, we can rock and roll.
Sounds good. Sounds good. Well, welcome, everybody. My name is Dr. Mike Cooper, like Joe said, and Greg said too. I go by Coop. I did practice for, pretty much in ODMD practices for the better part of the last 17 some odd years. And I see a lot of uveitis cases and a lot of just really, quite frankly, infectious disease. So this course is an homage to a lot of those different things. And I felt, even though it's the dinner hour on the West Coast, or if you're in Hawaii in the afternoon, or if you're on the East Coast, it's obviously going to be, past dinner time, but in the evening, I'd like to kind of, wake you up, so to speak. And this starts off with a video that's of a patient who has since basically, gotten quote unquote better. Really, the better way to say it is stable regarding his traumatic event, of which you'll see in a moment. This case was litigated. He did give me permission to actually show it. He did give me permission to actually illustrate the case in words. I did have permission also from his legal team to do so as well. The case is no longer in litigation. It's been settled. But this is a case of which, could end up on your doorstep at some point. So here we go. And we'll see this twice here and then another slide. But I figured again to wake everybody else up. Hold on one second.
Okay, you gotta hold your hand. Okay? Oh, okay. All right.
So I won't go any further because there's expletives and there's all sorts of commentary in there. But as you can see, this was on a July 4th weekend a few years ago. And this individual, we'll go into more detail as to what happened next. But that was his child, and that was a sparkler that was not going to shoot off from where they were. It literally was just what they call a quote unquote innocent sparkler, which is not really that innocent because it's got a lot of obviously gunpowder in there. So here is my disclosures. Obviously this information was of my own. I presented accordingly. That my relevant disclosures have been mitigated, and I've worked with everyone in the sandbox for all intents purposes. I'm also the co-founder of Intrepid Eye Society, and you can see that in the lower left-hand side. But I take no direct financial or proprietary interest in any of these companies, products, or services. So let's get back to it. Let's get into the actual case itself. But first, before we even do that, I'm going to pause for a second because I think that Greg wants to launch a poll question. And this is a good one because we want to know what's your comfort level in uveitis. How often do you see uveitis cases per week? Is it 5 to 10%? Is it 10 to 25%? 25 to 40%, or greater than 40%, or never? Go ahead and answer that question for us.
Coop, I was looking at some of the questions and some of the people direct messaging. All your disclosures have been mitigated, right?
Correct.
Perfect. Joe, put your hand out into the chat box. Thanks, Joe.
So while we're waiting for this, it's everyone has different comfort levels when it comes to uveitis and how they treat it and where they want to go with it. And this is, what you're seeing right here from a poll is concerned is not that uncommon whatsoever. A lot of us see it a small percentage of the time, but what you'll find here and the hope of this particular conversation is that you'll feel more comfortable by the time we leave each other tonight and how to actually manage these cases potentially if you see them come to your doorstep and the associated treatments that go along with them that some of us will be using or will be co-managing these cases with our other colleagues. So moving forward, we're going to get back into what things look like. But what is uveitis and where do we find ourselves as far as the prevalence and incidence? Now, I update these numbers because I give this lecture rather frequently, every year, give or take, 6 months to a year. And what I could tell you is that the numbers are not going down. That's number one. Number two, they are going up. They're not flat. And the other thing here is that the bullet of the last one there, prevalence has not been reduced in the past 30 years. So more cases, yet, we're seeing this run around here as far as the actual prevalence is concerned. And it's the 4th leading cause of blindness in the US. So, it's one of those conditions of which is lingering in the background in a lot of practice in a lot of cases. There's even a fair amount of subclinical cases that a cell is here, a cell is there, and I've seen them, I've caught them in practice, and it's rather interesting. And you start asking questions, of which we'll get to. So what do we do with uveitis patients? How do we actually, go about our daily lives when it comes to these individuals? Well, obviously you can see here, there's a whole litany of things you should be looking at, or might be wanting to look at. And obviously we're not going to read them all out, but history is crucial. That is one of the biggest, most valid components of any of these examinations when it comes to uveitis cases. A history is paramount. Pupils as well as a big one. Obviously, your best corrected vision, but I think we'll get into all of this obviously, but the cornea, the iris, the lens, all of these different features, you want to do a thorough examination, but asking those historical questions can be very important. What do those look like? Well, we can say here, and so like, have you had previous uveitis? That's a softball. That's great. But really what we want to know is, other questions that are more kind of almost they may seem at a left field, but they're rather important, such as, have you traveled recently? Have you eaten any exotic foods? Have you had any infectious diseases in the last 30 to 90 days? Any question that seems like almost like it seems almost obtuse in this patient base is not that obtuse, because it may uncover something of which you might want to lead you down a path of which will be very important. So all these things are rather kind of imperative when you're going through these different cases. And you can see here too, question marks on a macular OCT, DFE, visual fields. All these are of relative importance depending on the cases, especially as we go from anterior segment to posterior segment. So as I mentioned before, we got the case again. I'm going to see if I can't start and stop this, but it's rather difficult in this setting, but I'll give it a shot. The big thing is here that, like I said, what he's holding is a sparkler. He's lighting it up. His daughter is literally very, very close to him, and he's trying to give her first quote unquote experience with fireworks, and it doesn't go so well, obviously. So, we'll see it once more again. It actually, when you look at this, you'll see it actually ping pongs off of his globe, the lower inferior rim to be specific. And that's obviously difficult to see, but I'm just trying to walk you through it a little bit. So here we go.
Guys, you gotta hold your hand. Okay? Oh, okay. All right.
So it's rather traumatic for both the child and the adult. He was a 32-year-old Caucasian male. He was a same-day referral from the Wyndham ER. I saw him rather urgently, as you might expect. And, obviously swollen, painful eye, not, well, that's rather obvious that it was going to show up like that. And his eye was shut upon presentation. Actually, they patched him, which I wouldn't have done in my practice, but he came from the ER, which things happen over there, and they're just trying to do right by him. But I wouldn't have patched him in this instance. His vision was unstable with excessive tearing, and this is not his first go round with injuries. He actually had a previous paintball injury in the same exact eye as a teenager. So he is this is not his first go around. Like I said, he's a rather, quote unquote, unfortunately, a pro. So his vision uncorrected.
Coop,
Yeah.
I would hazard to say that if you looked at his old high school yearbook, he probably would have been voted boy most likely to become legally blind.
Yeah. Unfortunately, he seems to be a magnet for these things, and it's actually a good point. He has had other injuries, not ocular ones, but he's had other injuries in his past as well. So he's one of those trauma patients that seems to love the ER, and unfortunately, in this instance, this is his second go around with an eye injury, and his vision was 2200 in his right eye, 20/25 in his left eye. And you can see what obviously the positive findings themselves. The most germane to this discussion is a 3+ cell in the anterior chamber, but there was no flare, which obviously you probably might expect, considering this is inflammatory and it's more acute. There was no cytal sign. The cornea was intact. Obviously, you want to make sure that you put some fluorescein on the eye to ensure that there is no cytal perforation in that cornea. And obviously, with the vision, he's where he is. Gonioscopy. Going to step back for a second and say it is a crucial part of any examination. It's not, you don't always do it the first go around when you see a trauma patient. Okay. So if you see that and you're thinking to yourself, like, wait a second, why did Coop do a gonioscopy? Well, again, it was an intact cornea. You see the pressure as to what it is. He had actually an IOL in this particular eye, which, I'll share with you in a moment. So I chose this instance, my decision making, because of my experience and my comfort level. I did do gonioscopy to take a look at the iris, and also all those different structures that you normally would see in that space, to ensure there's no blood that's seeping into that area, which would lead us into a more serious conversation. IOP is lower in the affected eye, which is rather typical, because when you have oftentimes an acute iritis, or just an iritis case in general, you're going to notice that then that IOP is lower due to the fact that there's less aqueous production. The one caveat to that, not in this case, other cases, is that IOP can go up. And what's that one condition? It's herpes. That typically is the one of which you'll see IOP rise acutely in that instance. Commotio retinae was parafoveally present, along with multiple corneal scars. These were all more or less something that was pre-existing on the corneal scar side. The commotio retinae is, again, traumatic in nature. It's a shearing of the photoreceptors. They typically will reattach themselves, but it's something of which just to be aware of. So as I mentioned, an IOL. Well, this IOL is a bit different than the ones you may normally see. This is what I call a peekaboo IOL. And this one is something of which is both in the anterior chamber and the posterior chamber. So it took them about 6 to 8 hours to actually get this in the appropriate position from a haptic point of view from the surgeons, in this particular case. What you'll notice is if you look at about 10 o'clock, you'll see something that looks like a little bluish, almost like a hook. That's actually a suture that they had to use to actually affix this lens to the iris to keep it in position. So that was something of which then they got kind of a little bit frantic in the OR, and they said, you know what, we're just going to attach this right here and keep it in position. So you can see, obviously, this is some posterior capsular pacification, and they've created a little an in time here. This is essentially they did a YAG capsulotomy at some point in this past as well. So going forward, get a little closer, you can see it. And so what do we do for treatment? Well, a lot of you mentioned, obviously, you mentioned cyclopentolate, you mentioned homatropine, and I might have thought to use homatropine in this instance, but it wasn't available. So I had cyclo, and I just did it twice a day because he was pretty much, He was partially dilated to begin with, as you saw. They were just more to kind of calm things down a little bit, and any spasmodic action of the iris musculature, I wanted to ensure that I at least controlled it the best way possible. Durezol QID, I'm rather aggressive in these instances. As you might know, this is, if you think about this, is 2 times predacetates. When you look at the conversion rates, and typically, it's not a hard and fast rule, but like to hit it hard, hit it fast. That way we get that inflammatory response down. In this case, it was 3+ cell. He'd already had pre-existing generic COSOP on board, which could obviously account for the fact as to why his pressure might have been low, in addition to the fact he had traumatic iritis. The bacitracin was also onboarded by me in this instance because I wanted to at least have some coverage on the dermal surface, periorbitally speaking, to ensure there was no potential for infection. It was an open wound. I wanted to control as best I possibly could. So what happens next? Well, it's to me, in these instances, it's not instant gratification. You might want to have that, like, oh, I really want to see the cell go down to almost like, practically 1+ or trace, and that's best wishes in some of these cases like this one, where again he's had this is not his first go around. It took him 2 to 3 months for this to actually resolve, and it could take even longer than that depending on the instance and what might be happening. If he had actually an intact lens, that potentially could also complicate things, and that's why it could take longer. It could also lead, depending on the what therapy one might have chosen for this, as to the selection. It may not have been completely just more or less topical. It could be something else on top of that. His pressure did remain low and did not spike, but it could. And obviously be mindful of that retinal pathology from all those different areas of which is on the screen right here, especially the acquired optic neuropathy, which, it will eventually, likely in his instance, based on the amount of trauma he's had over time, it likely will evolve in that sense. So what about epidemiology and injuries? Now, selfishly, these are my 2 children. They are much older than this at this point in time, but my son is, as I've, and probably Greg and Joe have heard the story many times, is I became a partial dentist at one point because he decided to rearrange his teeth jumping off of a few different pieces of furniture. He has since got all his adult teeth. They look perfectly fine, but it's one of those ones of which boys tend to be more predominantly affected by injuries comparatively to women. So that you can see that right there. Perforating eye injuries make up 21 and 24% of serious ocular trauma and can lead to significant cause of visual loss. Most time it's preventable. It's just, a lot of the time it's common sense, and other times it's just, being at the right place at the right time. Ironically, my daughter is looking to actually become an orthodontist when she gets older. So, obviously my son's dental injuries have inspired her.
Hey,
So
Coop, before you get too deep, I have a question that came in directly to me.
Sure.
Regarding that picture of the anterior chamber. It says, was the anterior chamber pic taken pre-trauma ?
No, it was taken post-trauma.
Great. Thank you.
Good question. Yeah, I took a snapshot of that with my slit lamp camera when he first came in, actually, because it was one of the first times I've ever seen IOL in that fashion, oriented in that way. See many in IOL. That was a unique one. So the uveitis incidence, as you might expect, a vast majority of cases are anterior. And yes, you have your intermediate. Yes, you have your posterior, your pan, and those that are indeterminate. They're kind of somewhere in between and what have you. But you can see here that it's relatively equal bearing between on the anterior side, and most of them, quite frankly, as far as between male and female. So you can see here that this is a lot of patients that have undergone this particular study of 731,000, almost 732,000. So that's the incidence we have right here, and this is the prevalence. Prevalence doesn't change drastically too much, but you can see much more in here. Okay, in this way that the data is stacked. At the anterior, you have a fair amount more cases compared to the other ones. It doesn't mean the other ones you can't see them, and we'll go through this. We're going to go from front to back, but it's just one of the things to kind of just set the tone for things. So, poll question number 2: how comfortable are you managing uveitis cases? Very comfortable.
Let me get this relaunched because I bumped it by accident. Let me see. There we go.
There you go. So very comfortable, somewhat comfortable, neutral, somewhat uncomfortable, and very uncomfortable. Now, I could tell you while everyone's kind of doing their selections here, that when I came in at a training, I wasn't, I was relatively comfortable. I wouldn't say I was like uber comfortable, but in the same vein, I had seen enough cases and enough sites to kind of feel like I had a decent enough handle on it. But certainly, this is something of which via practice and just seeing enough of these things on a regular basis, you gain the confidence. You do your best to manage them. Is anyone perfect? Absolutely not. But it's one of those ones of which you learn over time. It's what they call practice.
All right, we got a good
results?
response here. Yep, share them right now. Here we go.
All right. Hey, that's great. That's 60% pretty much in that comfortable to somewhat comfortable. That's fantastic. Yeah. So for everybody, quite frankly, I hope to get you a little more comfortable, move you up one more ring. So where is it? Obviously we talked about a case and what have you, but what happens here as far as the different areas? And I kind of like to kind of, just quickly go from this one to the next slide because it gives me a better visual. I'm a visual person. I like to kind of understand where I'm at when it comes to, the different areas of which you kind of would expect to see these different types of uveitic responses. And so, obviously we have anterior, intermediate, posterior, and then panuveitis. And you've heard of probably choroiditis. You've heard of iritis. You've heard of all these different subtitles as to what might one call these things. And this is the kind of the International Uveitis Study Group. That's what they kind of essentially align them up as to kind of make things easier for all of us to put in our minds as far as what I call the visual buckets. So what are the signs? Well, these are the anterior ones that we're going to look at right here. And we have redness, cells flare, hypopyon, deposits in the lens, pupillary irregularities, iris color changes, high or low IOP, and Busacker-Kepi nodules on the iris. And that's not the only nodules, and we'll get to that too. But this is kind of to set the tone for what we're going to go through today as to what this is going to look like tonight, to understand what one should be looking for as far as the signs or really signals for a uveitis case. And so when we hop right in, we can look at things of which you're familiar with. KPs, fine keratic precipitates, or the other type of KP, which is mutton fat. Now, you typically would see a fine KP in a non-granulomatous case, okay? And then in the mutton fat one, you typically see that more in a granulomatous, which is an inflammatory or infectious even to that matter. So, but that doesn't always follow those exact rules. That's something to be aware of. It's not always a one-to-one. I see a fine one, it must be a non-granulomatous case. That is not always that instance. And I have a slide coming up, and then as we keep on talking through these, that'll illustrate that exact same point. You can have infectious disease and still have a more finer appearance to those KPs. So keep that in your mind. Not every case is textbook, as you might expect. Nothing really is, obviously, whether it's in our specialty or others. But this is one of the ones of which it does dance around a little bit, and we just have to be aware of it. And again, it's by experience, and it's also just unfortunately, I'm looking at a lot of pictures, and I've done that over the years a ton of times. And sometimes, you think you got it and you got it under control, and sometimes, unfortunately, you don't. So what are the symptoms? These are the typical hallmark ones of which we would expect with uveitis patients. The onset may be rapid or it could be gradual. Just depends on the actual agent or instigator in these instances. Blurred vision, big one. Acuity may vary. Floaters, eye pain, photophobia, redness, photopsia, which we'll get into a little bit. History of trauma, which we already just covered a little bit, but we'll go into further detail on, and the history of previous eye surgery. And in this instance, for that other patient we just talked about, could that have to be rubbing up against and cause an inflammatory response later on from that trauma case? Yeah, it probably could. It is a possibility of that. So what is the aftermath? What are the comorbidities of a uveitis case? This is a short list. This is not a long list. This is a short list of what could happen. I intimated about the optic nerve atrophy before, but there's a litany of other things, including what you see right here, specifically macular edema, retinal detachment, just straight vision loss, CMV or choroidal neovascularization, ischemia, and band keratopathy, just to name a few, and obviously of anterior synechia and posterior synechia, just to boot. The photoreceptor degeneration, that's something, again, is that you see as in the form of parapapillary atrophy, or you can actually literally all see as macular atrophy as well. And it can extend all the way through. So there's various presentations of it. So I called this the Rivers of Logic when I was training my interns and residents, because it's good to kind of have some level of understanding as to where these further bucketing points can go. So if there's no history of recent ocular surgery nor trauma, you should think about the following. Either it's non-infectious, infectious, systemic disease, and even further, we'll go into masqueraders down the way, but these are the main ones to kind of think about. Now, you may wonder why I kind of highlighted COVID-19, Marburg's, brucellosis, Lyme disease, syphilis. I did that for a reason, because those are more nascent entities of which, are either making news or have made news in the recent past. Obviously COVID-19, we all know that one is, but Marburg's is a infectious disease that typically you'll find not really in this country, although you'll find a few cases scattered throughout, but mostly in Africa. And it is rather infectious. It will, run through and burn through a population rather quickly. You don't want it, but it's something of which, it's certainly, it's on the same level as Ebola. Just for the sake of conversation. Brucellosis, we'll go into that in a little bit. Lyme disease, we'll go into that a little bit. Syphilis, we put that on here because it's made a resurgence in the population, along with other things like measles, but we're not going to talk about that one specifically. But you see syphilis in neuroretinitis cases, which is another one of those itises that we tend to talk about. Now, one last thing before we leave this slide is spondylitic arthropathies. So you may remember, the terminology in the past regarding, ankylosing spondylitis. Well, that term has kind of been, more or less sunsetted, and we've replaced it with the spondylitic arthropathies, which really are broken down into several different categories. They could be peripheral, which is mostly in the legs and arms. It could be psoriatic. It could be reactive, or it could be enteropathic, which is ulcerative colitis or UC, or inflammatory bowel disease, which is an IBD or IBS, and then Crohn's disease. All these are of the family, and we can do literally an entire lecture just on this condition alone, along with an HLA-B27. So that's where you tend to find these instances in these cases. Behçet's chronic granulomatous disease, JIA, which is essentially juvenile idiopathic arthritis, Kawasaki's, and the list goes on and on and on. So there's a lot of different disease states, but just want to kind of, curtail a question about like why I see ankylosing spondylitis. It's because that term has been sunsetted. So this is a rather interesting thing. And another thing to point out here is, as I move on, is that the gut is something of which we're noticing is a strong component of a lot of these different cases, and could actually lead to resurgence of a fair amount of them. So I promised you brucellosis. And the reason why I bring this up is because
Hey, Coop.
Yeah.
I know you're on a roll here, but I want to give the audience and our colleagues a little something. And I didn't see it in the slides as I was putting some together, some of the polling questions and the post-event. Maybe you'll bring this up, but I want some of the audience to realize is that when I do like a uveitis talk, because I always like to ask, what does the central nervous system, brain, testes, gut, and the eye all have in common? What is that? I'm not expecting you to answer, Coop. I'm asking the audience is to think the central nervous system, brain, testes, and gut, and the eye. What do they all have in common? And these are all organs or part of the body. I'm not sure if the gut would be an organ. And Coop just brought up the importance of it, but they're all what we call immune privileged, right? So that means if I go to Barcelona, Spain next year and have some food that my body's never eaten, that my immune system does not have a reaction to. And so that's probably the easiest. We're always introducing from our mouth to our, through our intestines, some type of strange food, but our immune system doesn't go and have some type of immune reaction. So that's called immune privilege. Our central nervous system has it, our brain has it, our testes have it, I think maybe ovaries, and then our eyes. So when you see this inflammatory reaction that's happening in our eye, our immune privilege has been overtaken. The eye really shouldn't react. So the immune privilege, something is going on. So like that's why whenever Coop goes through this lecture, keep that in mind, whether it's an anterior or intermediate or posterior uveitis or pan uveitis. Why has this immune privilege been broken? So think of it that way as you go through.
Yeah, I was going to get to that in a little bit, but thanks for bringing it up. We'll get there as far as when we go through some of the other cases. But thank you for the input there, and I think it's a valid one because it actually plays right into this case to a certain extent, because brucellosis is a bacterial zoonotic disease, and it's again what Greg just said. It's talking about someone may have ingested some food that was not exactly on the up and up. Now, why am I even talking about this? And you may have even heard of this. Well, a number of years ago, one of the major, I would say, food companies, and I'll leave it unnamed because we are being recorded, was sending their pork from this country after and after it was processed to a different country, China specifically. And then it was processed again and then brought back to this country, and or it was staying in China. And it's not to kind of more or less pinpoint a particular country, but it happened to kind of be in this instance the same area of the world of which we talk about with COVID and what have you and whatnot. But why am I bringing it up? Well, here's why. Because what ended up happening is in that part of the world, what ended up occurring is they had a massive outbreak of brucellosis because their bodies were being, more or less exposed to a bacterium that was not exactly native to their parts. And, pork meat, while we tend to like bacon and what have you, isn't exactly the most sanitary based on the population of animals. There are several different types of brucellosis, and you can see them down below, but I bring it up because it's not probably the first time, it won't be the last time, but it's something to be aware of when you see these certain types of symptoms. It's something to kind of keep in mind if it's a foodborne disease. It's why I mentioned in the beginning of this, as far as question to ask, have you had any exotic foods recently? This is why. So we get to our next case. 54-year-old Hispanic female presents with grittiness, light sensitivity, and moderate discomfort in her left eye, history of hypertension, asthma, and she had recently mentioned that she was bitten by a tick and was awaiting test results. Now, in the state of Connecticut, where I reside, Lyme disease, which is obviously what you might expect for this particular case, it runs rampant. Now, ironically, it doesn't live in Lyme, Connecticut. It's where it was, or East Lyme, Connecticut, where it was named from. As far as the endemicity and the highest endemicity, it actually was where I practiced, which is in the Windham County area, which is the kind of what they call the Quai Corner, or the northeast corner of Connecticut. I used to see cases, when I was at that particular practice, since moved on from it, at least several times a week. And in some instances like this one, we notice Lyme disease coming around the bend, and we're going to go into it as far as this particular case. Now, I call this, the bat sign, as far as the way that iris looks. It has that old school Batman sign. So the vision was 20/70 in the right eye, pinhole to 20/30. Sorry, yes, 20/20 in the left eye. Everything else is pretty good as far as the entry-level examinations. Pupils were slightly sluggish, and as you might expect, considering what you see to your right. The positive slim findings, you can see there 2+ cell, 1+ to 2 fine white KPs, several areas of PSOD, posterior synechiae, and the pressure once more in the affected eye is 12 and 17 in the unaffected eye. The fundus examination was unremarkable. And, we talked about infectious disease, inflammatory disease. And again, this is the instance I told you about. You might have thought potentially you were going to see, some more mutton fat ones. That was not the instance right here. By the way, one thing with Lyme disease, of which you might not know, is that it's in some instances that you actually see more of a superficial punctate keratitis appearance, which might fool you into thinking in these earlier cases that it's dry eye, because they present very similarly. And it's not dry eye at all. It's actually Lyme disease, but it progresses in different stages to get there. And eventually you have more of an anterior scleritis-like appearance that particularly presents as the case evolves. So it's rather interesting that you can kind of see some of these concurrencies and also some crossing of the rails in many of these instances. So what was the treatment? What did I do with this individual? Again, cyclo, and again, I would have potentially used homatropine if it was available, but there was a shortage at this particular time, so there was no way to actually receive it. I did use Durezol in this instance, QIDOD. Again, we want to hit it hard, hit it fast, and then taper it down. We don't keep it at QID forever. I didn't mention that last time with the other case, but it's not something of which we derive this from, from more or less keep it at QID for weeks upon weeks upon weeks. I do cycle it down pretty quickly. But in this instance, as you can see with the picture to your right, that bat sign was broken down with the use of the cyclo, and obviously the decreasing anti-inflammatory response. Vision improved after day 3 to 20/40 from 20/70. Pressure was stabilized. Still had the 1+-2 fine KPs, a little bit of less cell, and obviously, like I mentioned before, the PS areas were mostly broken. You had that small area that was still kind of, been bugging out, but mostly it was actually, in a good place. You see at about, say, 8:30, 9 o'clock, and about 6 o'clock, there's still some adhesions there. Eventuality is actually did break completely, and it went back to normal functionality for the most part. It obviously, whenever you have one of these cases like this, pupillary function tends to be slightly impaired if you look really closely, but more oftentimes not. If it happened just once, it's usually it bounces back pretty quick. But then that's just one of those aside moments for you. As you might expect, like I kind of hinted at before, this is a case of Lyme disease. It came back for Borrelia only. I say that specifically because, when you get Lyme disease, it's a rather generic term. There's actually lots of different types of things that are classified under the guise of Lyme disease, but it's just one thing to notice. So what are the collaborative care steps that we walk through when it comes to these types of cases? Well, if you're in the state of Connecticut, we report it to the states, the Department of Public Health, and every US state or Canadian province has forms to report these things. I send a letter invariably to the PCP, whether electronically or by paper, by old school snail mail paper, but most oftentimes it's the form that I usually have. I start this patient on doxycycline. I have oral privilege in the state of Connecticut, 1 tab, BID for by mouth for 14 days. Because obviously we want to treat empirically, but I wanted evidence of this first. Now, one key thing, even though it's not a Lyme disease lecture, I do want to mention, what's the halo of time you have for, giving out orals, whether you chose doxycycline or, even vancomycin in some cases or something else. You have about 72 hours, give or take, it's within that certain part. Now, there are medications that are in development, from companies that are out there. So some of you probably have heard of a company called Tarsus Pharmaceuticals. That company has a few things in their pipeline that potentially may look to actually, treat Lyme disease at some point in the future. So just to be clear about that. So that's an off-label usage, but it's community standard of care. So we use that. There was a Lyme vaccination way back in the day called Limerix, but that has since been taken off the market because there was a number of deaths, and it didn't have enough, essentially didn't get enough pull in the open market back in the late 1990s, give or take, to early 2000s. So I made the patient aware that they were going to see a infectious disease specialist in this instance to co-manage, because that's what I like to do in these cases, to ensure that they have full coverage. So now we're going to get to our poll question. So Greg, have at it.
Let me read you these couple of questions and I'll launch the poll. One came in privately and one is in the chat box, but they're both going after the same thing.
Sure.
Should Durezol now always be the go-to, or is Pred still considered, okay, since it's the cost? And then another one came in, is Durezol better than Pred Forte eye drops? I'll launch the poll.
So I'll answer that question. Great questions across the board from the internal question, external one. Durezol, to me, is from my perspective is adherence. I think that if I wanted to kind of do it, in some cases every hour or every, in 8 times a day plus, That's a lot for patients sometimes to do. Is it medically necessary in some instances? Yes. Is it a cost thing in other cases? Absolutely. Is Duracell proven to be more effective than Pred? No. I think that you can probably make a case for either one being equally effective in most instances. It just depends on your comfort level and the amount of dosing points you want to have for that particular patient. I found professionally in my clinical practice that Duracell does a great job. It doesn't mean it's the end all be all either. There's many other ways to treat these conditions, and you can vary the dosing. And that's what I was, intimating before, that there's various ways to actually attack these cases.
Coop,
go ahead, Joe,
I,
then I'll weigh in.
In my experience, I have used Duracell in inflammatory conditions that Pred Forte didn't touch.
Mm-hmm.
And it really does. The fluorination, the difluprednate, the fluorinated prednisolone does make it stronger to the point where you don't need to use it as much. It is now generic, at least in my area. If a patient was uninsured, they can probably get it for about $60, and that's probably peak. But one thing that I would caution from the experience, and there's some literature behind this, is don't treat it the same as Pred. That if you have a lot of inflammation, all right, well, let's use a lot of Duracell. Every hour while awake. There was a paper that came out in the optometric literature, and I thought it was very good. I don't remember who the author was, but it was in the OD literature, and it was really good. It was a meta-analysis looking back at pressure spikes associated with Duracell.
Right.
And they looked at various published cases in the peer-reviewed literature. Embarrassingly, one was mine that they put in there. And the commonality that they found was people were overdosing Duracell.
Right.
They were going beyond the 4 times a day recommended dosing. And when they did that, they more likely had the pressure spike.
Yeah.
So if you're worried about the pressure spike on Duracell, just don't overdose it. Keep it at 4 times a day, and you're going to minimize that risk.
Right. And that's a great point. And, that's why you see me on these cases doing QID in most instances, and not 5 times, 6 times, 7 times, 8 times, because there is a point of a threshold where you will actually see that spike, even in a case that has normalized IOP. And that's something of which you want to avoid. And that's also why one must be diligent with the tapering, and not to bring it down so quickly, where you're going like you thought with your gear shift with Pred, where you might have thought like, well, it's at 8 times a day, I can drop it almost immediately down to potentially 6 or 4 times a day with minimal repercussions. Every case is different, obviously, like I mentioned now multiple times, but you probably would bring it down a single dose each time, from QID to TID to BID, and this is for Duracell, by the way, down to QD, and then you obviously can make your clinical decision based on how you want to proceed. But obviously, in cases that have that are significantly pro-inflammatory, you'd want to be more cautious with Duracell just from the jump. But that's a common sense call that you have to kind of make when you're actually going through these cases. But thanks, Joe, for the input there.
Yeah, my comment was going to be very similar to Joe's, in that, kind of judge the uveitis. If it's kind of a mild little uveitis, you can probably get away with Pred Forte. You got that smoking one that's the worst you've ever seen. Limbo injection is hot. You've got Synekia. You got a smoking eye. Duracell would be probably a way to maybe start off in that situation. Joel mentioned that Duracell has no generic, or maybe he's asking if there's no generic. I believe it was 2021 where Duracell, I think it's been about 2 years now that we've been able to get Duracell generic. And like Joe said, it's typically not that too expensive, or you can go to GoodRx and use that. That's out there. I got a private message. Go ahead.
Another thing that I noticed, Coop, in using this, and see if you agree or disagree, if you know the same thing. Very common to get a kind of a dense core central punctate keratitis, like a PE, a PEK, and I think it's the oil emulsion that causes that.
Yeah, I get that too.
Don't be afraid.
Yeah.
Don't be afraid if you get a little central epitheliopathy.
Yeah, I have seen that in a lot of these cases, not all these cases, but I have noticed that. I think it's the oil, and I think it's also the formulation itself, as far as the medication. Steroids tend to kind of, essentially slough off cornea rather readily, and if given enough time and dosing. And when I say dose, I mean the amount of days the person's been dosed over. So you might actually see that in some of these cases where you're constantly going back and forth, and they may have already had some epitheliopathy to begin with, which further enhances the potential for this. What was the private
I have
question,
another
Greg?
private question that came in here. It says, and I can feed off of this at the end, but if you have an intermediate or posterior uveitis, does Dorsal make better sense because it can penetrate the tissue? That was a question. So
yeah, I mean, the answer is it depends on the type of uveitis you're working with and the severity of it. It could make a dent to a certain extent, but you're starting to trail into a different world with intermediate uveitis as far as the treatments and what you'd utilize for them. You typically would support with topical, but that wouldn't be your primary therapy more than likely.
And when you get a posterior intermediate, usually the number one reason why the vision goes down is CME.
Correct.
So that might be a reason to use Dorsal, is for, again, that CME aspect of it. As Coop will probably talk about, an intermediate, it might not be helping the intermediate or posterior. So
right. It's more complementary.
Michael Tran has a couple good questions. One, I think, has been an easy one to do right now. Do you use phenylephrine 10% to break the posterior synechia?
Yeah, you can. I mean, it's something of which I don't usually use that often, but I mean, I don't think I've typically reached for it, but it's certainly something which you could use. Yes.
Yeah, I'll use it, but to be honest with you, the steroids will dissolve the fibrin, and they'll do most of the work. The cycloplegia will help. If you need a little bit extra, a drop of phenyl. If the patient is not any sort of cardiac risk or older, I would do that. Certainly a younger person, but for the most part, steroids to dissolve that fibrin. And he also asked I think a very loaded question, which I think we're probably going to defer for now. Do you order lab tests for anterior uveitis that's granulomatous? I'm sure, Mike, you're probably going to have that in the presentation later. Is that correct?
That's correct. Yes.
So you just have to hold on for a little bit.
Yes. So tipping back towards Lyme disease, we'll talk about that there are 22 different variants that can cause Lyme disease from tick bites. And as you can see here, there are several different ones I've mentioned: Mimotoi, Powassan, and then the ones of which I really want to kind of get into is Babesia and Anaplasma, because that's ones I said before, this case was only Borrelia, but there is more evidence in the literature that's pointing towards co-infections, specifically Babesia and Anaplasma. And I have a great case of this in the lecture that were fortunately, depending on how you look at it, 17-year-old patient came in with essentially those dry eye-like symptoms like I mentioned before. And in fact, invariably, he mentioned he had a tick bite 6 months prior to. We tested them, and he came back with the dirty dozen here, or in this case, the top trio of Borrelia, Babesia, and Anaplasma. But you're going to see this more frequently probably mentioned in the public space, and it's something which has been increasing rather rapidly. Now, I'm not going to go into this very, very deeply, but you can see here, this is how you were to test for Lyme disease, and it's simply put on when doing your lab work. You can put down, want to do a Lyme disease titer. If it's not a click off little checkbox, whether it be online or via paper, it's rather simplistic. To me, I kind of like it, but at the same point in time, it's not very specific. It's more of a generalized test. I kind of equate it to a Mantoux test, which is the old school test for tuberculosis. Obviously you can do quantiferon, which is a much better one, and I think, from a specificity and sensitivity aspect. But certainly it can be helpful, and it can work in most instances. I typically also write down the IgG, which is immunoglobulin G, and immunoglobulin M, which is looking at both the in the moment infection and the infection that may have happened in the past. So you're looking at these different areas, and you're looking at, for Lyme disease specifically, they will usually tell you if you have at least 5 IgG bands, that is a positive. That's the acute side of it. The IgM is the more chronic side of things, and that's something of which to be aware of. I put this up here so you can see Babesia and Anaplasma and actually ehrlichiosis along the way, because those are all things of which play into when you look at Lyme disease as far as the Americana. These are the ranges. This is something of which you want to be aware of. This, and when you see it, it'll the great part is a lot of lab testing tends to kind of actually give you the normative range and then illustrate to you in most instances where it is in relation to that. So that's something of which is to be aware of. So we'll go in deeper into Lyme testing and so not Lyme testing, but to essentially lab testing and serology testing in a little bit. But I wanted to give you a taste for this right here. As far as Lyme treatment, you've heard of obviously doxycycline, and that's something of which we can use in most patients. We can't obviously use it in those individuals that are less than 8 years old. So that's a little bit of a contraindication. And we can use other medications along the way that can be used in that pediatric population if you so choose to do so, and if you feel comfortable managing those patients. A lot of times you co-manage these, whether you're a primary care doctor or infectious disease specialist. It is your choosing as to how and comfort level as to how you see things. So I will say this is that vancomycin, while it's not in this slide, I did kind of point it out before. It is something of which you can use in these cases. It's obviously not standard of care, but it is something to point out that it has been used and it has been thought about for these particular cases. Also, doxycycline, it mentions 100 milligrams. Well, when people have recurrent Lyme disease, doesn't mean that they're going to respond to that same dose again and again and again and ring the bell and actually have, after their flare up, respond to this and decrease their symptomatology and quite frankly potentially their infection. But mostly likely it's mostly inflammatory. So what I've noticed is that patients will actually start to slip into not 100 milligrams, but they start to go to 200 milligrams twice a day because they've had a tachyphylactic response to the lower dose of doxycycline. So just something to be aware of if you have a case where it's been recurrent enough. So now we go deeper into babesiosis. And in this instance, you need 2 different things, a combination therapies, and it could be 2 different types. You can do atovaquone or in addition to azithromycin. And the dosing is right there. I won't read it off to you, but then your other 2 choices there, you can do clindamycin, or you can do an IV of that plus the quinine. So you can do a few different things, but combination therapy is the way to go in a lot of these cases. As I pointed out here, this combination is a standard care for severely ill patients who are usually in hospital-based settings, or they're just elderly and they've had a lot of other comorbidities. So clindamycin orally or intravenously, in addition to quinine. So treatment is 7 to 10 days. And the good news about Anaplasma is actually the same treatment, no matter what, as you would get with Borrelia. So you don't have to kind of go through a cocktail more than just a few medications in these cases. Now, again, it's comfort level. Can you actually manage these cases in your state? It's very, obviously variable, but it's good to kind of understand what this looks like in these given instances. So just something to kind of be aware of as far as the different, facets and ways things actually happen. And as I mentioned right here, patients who fail to respond clinically to doxycycline monotherapy after 72 hours should be evaluated for an alternative diagnosis or the possibility of a Babesia co-infection. So if you're not doing the Lyme testing, specifically for those 2 or 3 different pathogens, you might want to consider that if you only just ran the Lyme titer by itself. So what's the Lyme map of the United States look like? And this, this is taken from a few years ago. It really hasn't changed that drastically. But, this is the different maps of which you'll see. And the hot spots obviously are in yellow for these different types of ticks. And the pathogen is actually in parentheses. So I won't go through that, but you can see here, you have all these different types. No matter where you are in the country, you're going to find some type of tick probably, in your parts. Now, you can't see if you are from Canada, don't worry, you have it too. It's up there as well, typically closer to the borders and actually is more towards the Arctic Circle, but it is creeping up. specifically from the upper Midwest into Western Canada typically, and obviously on the East Coast, you see a lot of cases in Newfoundland, Nova Scotia. It's a high concentration of cases. So if you're from any of those parts, be wary of that, and just keep in the back of your mind that they may have Lyme disease solely, or they may have actually Lyme plus a little bit of uveitis built into this. So these are all the different types of things you might see. So we have all these different areas. So here's the next poll question for you. In your geographic area, how common is Lyme disease? Go ahead and launch that poll. So like I was mentioning while this is going, in my area, we see a ton of this. And I've lectured all across the country, and it's so variable as to, how people, come encounter with a patient. Actually, this is the fourth one. But you can answer this too. I think we may have a repeat on the 4 and the 5. But pretty much, it's so variable. But in the same vein, it's something of which you'll see rather frequently if you ask certain questions. I typically honestly ask patients, and maybe just I'm geared towards it. Have you ever been bitten by an insect? As far as my protocol for whenever someone comes in with a red eye of some sort. So that way I kind of can just either check it off as like they've had a past infection or past tick bite or another type of bite, or they just say, no, I don't have it. There we go. So I'll be interested to see what people say on this one, because it's rather interesting. And
it's just this says 3 and that was listed as 4. So
yeah. So I'll keep going and I'll talk to the next slide so we can keep moving to keep the material going. But the one thing I just mentioned about asking certain questions is rather important when you have cases like when you have patients who have alternating unilateral HLA B27 associated infection, not infections, but inflammatory conditions. This is kind of just to kind of talk about the poll question right here. This is this is what I expect to see. Kind of it's all over the place when it comes to where you are, how much Lyme disease may be present in your given geographic area. Explosive onset and rapid resolution. That's a lot of these Behçet's cases. It could be VKC actually, which we'll get to later, and other B27 associated diseases. VKH is one of many of a litany of other HLA related conditions of which you might come encounter with, along with bird shot and many other things, which is obviously a choroidopathy. So now we hit into a case here of sympathetic ophthalmia. And I go over this case for a particular reason, because it has an eye-related historical significance. You can see that it's a rare bilateral granulomatous uveitis. It's due to trauma, less commonly surgery, and it's typically in one eye, starts there, and then it may trail to the other side rather quickly, explosively, to be frank with you. And then you start to kind of develop this autoimmune response. And Greg had mentioned this immune privilege. This is that exact moment to a certain extent, where I wasn't going to mention it, but it does actually run germane to the conversation, because you're having an inflammatory response and the body cannot get over the hump. It cannot manage the inflammatory capacity of which has been thrown in its direction. And we see this occurring in this particular population. So injuries, to onset, it's really super variable. It's kind of like some other things that you can see out there, like angle recession glaucoma, where it could happen within 6 weeks, or it could happen like 30 to 40 plus years later. So it's rather interesting. But most of the cases tend to happen within the first year. Inflammation is granulomatous. The choroid is diffusely thickened with lymphocytes. Sorry, it's spelled wrong. And there's nests of epithelial cells and multinucleated giants, which are referred to as Dallen-Fuchs nodules. Now, Dallen-Fuchs nodules are really kind of pathognomonic for this particular case. And you see them kind of laying on top of the retina. And it's rather interesting. Dallen-Fuchs actually also will show up, but not, they're not called that specifically. It's more just not nodules in some cases, as you might think about them. They actually show up in the iris as well as more like dome-like lesions to a certain extent. It's like these thickened little areas on the surface of them. So you'll see that in that way. Now, I promised historical significance to the eyes. Who is one of the patients of which we kind of, could think about in this instance? Louis Braille. So he was injured age 3. The instrument, unfortunately, of choice in this instance was an awl, which you see that's next to his picture there, his bust actually. And what he was doing And the story goes, from what's been recalled, is he was using this to work leather, and he was working this in a shed or in a barn, and he was, working it, and this is done as a child, and as you can see, age 3, and he slipped, and the awl went into his eye, and from that point forward, unfortunately, he was blind, and it happened rather rapidly. But what's come out of it, obviously, is Braille, as you might expect us to kind of talk about that for a moment, but also these things called Legos. Legos have actually, over the years, in recent times, they've actually created Braille Legos. So you can actually put those on a board, and you can feel your way through and read language in that instance in Braille. So rather interesting historical backing there. So River Logics Part 2. So drug-induced side effects. Now, moxifloxacin is a question mark. The literature, kind of like milk, it says yes, and yes, it could be, and potential for a uveitic response. No, it can't be. It's not obviously the moxifloxacin you'd see as a topical one that we've used, whether it be moxifloxacin generic, like obviously generic for Vigamox or something else. But it has to be on this list because there's always that question mark. Prostaglandins, as we all know, because in the one call out there is you don't want to use these in uveitic cases or pro-inflammatory cases. Same thing with molecules like pilocarpine, it's pro-inflammatory. You want to avoid them. Brimonidine as well. Brimonidine in higher doses and consistent dosing, not the stuff of which you'd probably use if it was, say, something that was over the counter that you can use now readily to get the readout, named unnamed, or if you were to mix, say, brimonidine from a quote unquote glaucoma drop that's either generic or brand name into a bottle of refreshed tears to make your own certain mix to kind of control the pupillary response, say for post LASIK, which was used way back in the day. White dot syndromes. Occasionally, uveitis is confined to the eye and there's no underlying systemic condition, but the etiology remains unknown. This is one of those ones of which, when we get into the many phases of choroidopathy, in this case, choroiditis, it can be very super variable. And each of these has their own specific presentation. We'll get into it a little bit, but not a lot, because again, that could be a whole entire course onto itself. And this is the crash course. So we're giving you everything all in one shot. No pun intended with the bird shot. Then you got the masqueraders in part 3 here. Now, this is where it gets a little more serious because, I've seen these instances where you get these malignant melanomas or, obviously, retinoblastoma and lymphomas and sarcomas. But, it's one of those ones of which, they tend to give you that pro-inflammatory response. And you're thinking to yourself, geez, what could be going on here? And you're not seeing anything specifically until, unfortunately, minus the retinoblastoma, until potentially it's too late. Because it's typically kind of almost in a sense it's the best way to describe it is it's almost like it's an end user agreement. You've had these other neoplastic seeding in other parts of the body, typically malignant, and then all of a sudden you're starting to see a uveitic response in the eye without any other call signs. So, it can be rather variable. And obviously, melanoma in the eye, you see choroidal melanomas, and they can distribute, they can create these inflammatory responses. I've seen a host of them, but it's just one of those ones of which you have to be aware of. Any one of the non-neoplastic ones, we can see as well in practice. The first one, the intraocular foreign bodies, are not terribly common in optometry practices across the board, even in ophthalmology practices. But it's just to kind of keep in mind of which you can see these like a dropped nucleus, or say a penetrating wound, and thought they got all the actual insult out, like say a staple or a nail, and some of it finds a way to penetrate all the way through, and it flakes off, and you have some rust in the eye. I've seen a bunch of those that have occurred over the years. And obviously, we're not working on those cases. We're co-managing those cases, and we'll get them back in their chair, typically, hopefully, at a later date and time. But those are just things to kind of be aware of and what have you, as far as the things that could be manifesting themselves and create an inflammatory response that may not be classically associated or called uveitis per se. So this is the bonus case. We got a case right here of a patient who was out in Kenya. And this again trails back to history. These are her pictures that she took Ironically, people kind of are very show and tell with me, unfortunately, and she did actually raise her shirt and take that picture. And what happened here? Well, in this case, a patient comes from Kenya. She's been there 18 plus times, quote unquote, never had an issue. And then she comes in and says, like, I got scratched by these feral cats. And I don't know, what's going on here. But I'm having this blur of vision. I'm having, red eyes, and I don't know what's going on. So, that's the case. But what are the historical questions you might want to ask? Where are you? What is your diet look like? What is your animal exposure? In this case, obviously scratched cats. Where have you traveled to recently in the past, either a few days to 90 plus days? What are your sexual habits, which obviously, trails back to syphilis and other types of communicable diseases like chlamydia as well, and many others. We can kind of trail back to these very easy softball questions that you can add to your armamentarium to ask in lock, stock, and barrel to get some really kind of data-rich information from these individuals to get to the bottom of this. Obviously, she gave it to me right away, but I may have had to dig to actually get the information. So in this instance, like I said, she was coming back from Kenya. Now I called actually in this instance the CDC, because I wanted to see if they had any guidance, in this part of the world that they've seen certain pathogens that may be linked to cat scratches. Besides, obviously, the easy one we may think about, which is Bartonella, But it's in this case, I did test her for that. It was very specific on this one, and a few other things, but it came back negative. So I called at least twice, didn't get an answer. I treated her empirically, with topical agents, than some of the ones of which we've talked about before. This case, I actually did use Pred. It wasn't a very, acute, 4+ cell here, 3+ cell. It was like about 1+2. So I was like, I feel comfortable just using straight Pred in this instance. I use a TID. In this case, actually, was bolt eyes, because it was sitting there and stewing, and considering she had been over in Kenya for a number of weeks. So she recovered rather quickly. I also gave her an oral as well. I gave her, in this case, I gave her amoxicillin. I could have given her doxycycline, I suppose, but I'm sure how much validity that is in this particular case, considering it wasn't what you classically would consider something that what you'd use doxycycline for from a pathogenic standpoint. But I did use something that was a little more broad spectrum. Could I use something else? Yes, I could have used something that was sulfa based. I could use something like Bactrim. Any one of the antibiotics that are more popular. Could have even used fluoroquinolone if I wanted to. But it's just one of the ones of which I try to kind of keep it as easy as possible for myself. I did obviously refer her to infectious disease, and they couldn't even figure it out either. But she did get better rather quickly after I was treating her, so that I felt rather comfortable that she was on her way. But these are the kind of the weird wackadoodle cases that you can see sometimes, of which are not the typical that you'd see coming through the practice. And just to kind of, for completeness sake, for that case, since it was the bonus one, I did do it, like I said, prednisolone acetate and TID. I cycled her down pretty quick within about a week or two, down to rather pretty much once a day for about a week, and then I stopped it. So she didn't really need it in this particular case. I didn't use any cycloplegic agents, because again, it wasn't a very inflammatory case per se, even though it was bilateral. It was almost like smoldering to a certain extent, but a very weak smoldering from my perspective. Again, it's one of those ones of which it's comfort level. Could I have done it, BID down to QD? Yes, I could have. Could I have done it, on top of that, more cycloplegia just to kind of control more of the muscular response in the iris? Yes, I could have. I just chose not to in this instance. So next case. 60-year-old African-American female presents with a history of previous bouts of anterior uveitis in both eyes. Her medical history is pertinent for diabetes mellitus, hypertension, and sarcoidosis. With regard to her ocular history, every time she has a uveitic episode, her intraocular pressure became elevated. So not going to ask you to kind of, the audience for these questions, but it's one of those ones of which these are sort of things of which we want to know what's the differential, how do we counsel them, considering it's recurrent. Patients are rather frustrated that they're having this consistently and wouldn't call it religiously, but kind of having a number of these bouts of this particular inflammatory response. And as you might expect, this is typically, and obviously she checks the boxes for sarcoidosis with her ethnicity and also the age, and also on top of that, the the recurrence and what have you. So, what's that look like as far as, what do we do next with these cases? Well, we like to kind of get a chest X-ray. That's helpful to kind of give us some more information regarding, the pleural structures to ensure that we're not missing something. You can see you can see here from stage 1 to stage 3, there's obviously a difference there. You can see that there is some almost, where there was some, nice and easy, you can see the rib cage, you can see all the different structures rather, clearly. You start to see some dropout at classically as the patients tend to get older over time. So, and that's, part of this particular, etiology or pathophysiology of this disease state. You can get all these different areas of which, from a review of systems that can, partially into somewhat being involved. But, it is something of which to be aware of. And to me, like I said, chest X-ray is still the number one method of diagnosis, 90%, give or take, waffles a little bit here and there. But, we look at, obviously in our training, we heard obviously the buzzword of serum ACE levels and elevated serum lysozyme. So that's something of which to be aware of as well. But to me, that I tend to send these patients for a chest X-ray to identify if it's bilateral hilar lymphadenopathy, or BHL for short. So that's something of which is to be aware of in these instances. Do I do a TB test in a lot of these cases? No, but if they are overseas, it's something of which is to be aware of, because they have got that little, essentially that vaccination, they get the BCG vaccination, and so that almost like that punch in the side of their arm for that particular pathogen. So just be aware that you'll see that in these cases. So.
Coop, go ahead and take a little breather there. I know what it's like to be on your end, and let me chat about that ACE level, that angiotensin converting enzyme. And you're really, for the audience out there, going to get that to be elevated when you have one of those active inflammatory nodules, which can be anywhere in the body. But typically when it's in the lung, remember, angiotensin converting enzyme regulates our blood pressure. So it hangs out in the endothelial cells of our capillaries. So our lungs have a ton of capillaries, and we're exchanging the oxygen. So it's just our lungs are this capillary bed, also regulating blood pressure inside those capillaries. Again, those endothelial cells have that angiotensin converting enzyme. So think of kind of that bubble wrap, that if, when you pop one, it's no big deal, but then, you take the bubble wrap and you pop a whole bunch and pop, and you're popping a whole bunch. That's what's happening when you have an inflammatory granuloma. It's popping all these capillaries, and that's where your ACE levels can go up, or your angiotensin converting enzyme. So that's why, it can be positive or it can be negative. And I agree, that chest X-ray is it needs to be a part of that laboratory testing.
Right. Perfect. So this is the lucky number 7, as far as the the different signs you might see in these cases. And it's something just to kind of, I would think that is this one of the ones of which you want to take a mental snapshot of, because a lot of these cases you can see a litany of different etiologies and really this, in this case, signs. But when you see a mutton fat KP, when you see, and this will go into Kepi and Busaka nodules in a little bit, but you also may see all these different things, strings of pearls of these snowballs, and really snow banking as well. When it gets more intense, you can see choroidal and peripheral lesions. They can be both active and also atrophic. And then on top of that, just to kind of, kind of amp it up an extra few levels, you can see periphlebitis, which is, with plus or minus some candle wax drippings, and then retinal macroaneurysms in the inflamed eye or eyes. I say that because it can happen actually. You can see these in some cases in bilaterally, rare, but it can. Optic disc nodules, granulomas, and solitary and choroidal nodules. So, it's one of those things of which you can see all of these different signs, and obviously you get the symptomatology we went through before that you can see in these sarcoidosis cases. So these are the 7 signs of intraocular sarcoidosis. Now, in this case, here's the case itself. 20/60 vision in the right eye, 20/80 in the left eye. And really we get down to the positive findings. 2+ cell, 1+2 fresh mutton fat KPs inferocentral. I did see, and this is where you get into the residual previous bouts conversation, as she did have some, some residual brown color KPs inferiorly, which gives you the indication it's been there and she had previous in bouts of this. And obviously there's, in this case, no PS, but there were pigmented areas in the lens capsule, which again means that she probably had some, some PS in the past, of which is, you can see these areas that lice themselves to what Joe said before regarding the steroid usage. It probably laced them along with the fact of using, a cycloplegic agent. There were several iris nodules at the pupillary margin, and this is the IOP. We did see some vitreous snowballs inferiorly. They were pearl-like, but they weren't a string of pearls, and there was no hemorrhage. So this is a little bit lighter than those 7 signs I just talked about before, but it's something of which just to be aware of. Now, what do we do to treat her? Now, again, this is different. You saw, like I had cycled before, and I talked about some other types of agents. In this case, I use atropine instead of homatropine, or or cyclo. Controversial to a certain extent, but I wanted to kind of, make sure I didn't have something that in this instance that was going to potentially flame back up on me. And I wanted to kind of hit it with something which was going to really paralyze that muscle, even though it was rather aggressive. I only used it for a few days, but it was one of those ones of which I wanted to really kind of get to this pretty quickly. And the Predacetate, the same thing. Again, it's one of those ones of which, knowing this case, you think to yourself, 2+ cell, yeah, I see some mutton fat KPs. Geez, that seems like a lot to throw at a patient. I think in this case, from my professional experience and seeing a number of these, I wanted to kind of get as aggressive as I possibly could to decrease the inflammatory response, not evolve into something more than what it is. And obviously talk to the patient about their systemic health and making sure they see their primary care and also their specialist, to manage this case. Because, while we're using steroids, for these individuals, quite frankly, and this is a question I've gotten many, many times, is like, well, what do you do with these that you have actually a pathology? Well, we want to make sure they're being treated appropriately by not just their primary care, but by their specialist. It'd be rheumatologist, endocrinologist, infectious disease specialist, because in many instances, these conditions are precipitating these types of inflammatory responses in the eye, going back to that immune privilege commentary that was mentioned a while back. So we went from, in this case, post 7 days, vision got better, IOP is stabilized, more or less is about the same. You have cell that's gone from 2+ down to 1+-2. KPs have gotten a little better, and there were no iris and nodules now at the pupillary frill, whereas they were kind of circling the wagon before. The vitreous snowballs were still present, and I expected them to be in 7 days. I did not expect them to actually go away. And Greg and Joe, feel free to chime in this instance. But in my point of view, you're not going to expect snowballs to go away rather, quickly. It does take a lot of time to process the inflammatory response, especially as it amalgamates in that posterior segment. So feel free to kind of chime in there while I move forward.
Yeah, the 2 comments I'll make is, the first one is, I don't think it's controversial to use atropine at all. I started off with the polling question that I probably use atropine 99% of the time if I'm reaching for a cycloplegic, and it looked like a lot of the audience, reach for atropine. My comment on your snowballs is that it's an avascular area. So it was hard for them to get there, slow for them to get there. So it's going to be slow for them to disappear. So yeah, I agree with that.
Yeah, not to mention the fact that from what you're saying there, it's going back to the commentary before about does Durezol penetrate enough into the intermediate and posterior segment areas? It's just simply does not enough to affect change in a rather rapid fashion. I mentioned the atropine just to kind of come back for a second there, is because I have been asked many times, and I like you would probably be a little more aggressive and would like to use atropine probably a little more frequently in many cases. Go ahead, Joe. I started to cut you off.
Oh no, snowballs can last for years.
Yeah. Agreed. Agreed. So, moving forward here, we have, what are the collaborative care steps? Obviously, as I mentioned before, I kind of intimated to this, sending a letter to the PCP is important to give them an idea as to what we're seeing, and in this case, we did order blood work to compare to normative levels that I received. And I made an appointment for this patient to see pulmonology. She was not seeing a pulmonologist. Patient may be made aware that she may need some oral therapy, and I just listed a few different choices in here to kind of just spark some thoughts in people's minds as to what might be actually used, and depending on the level of severity in these cases. There is potential, and again, this talks back to the to going beyond just the topical, for Kenalog injection, she may need cataract surgery, depending on the amount of inflammatory response over the years. She could develop a PSC depending on the amount of steroids used over the amount of bouts that she has as time moves on. Could she be a candidate for, if she does develop glaucomatous, findings? Yeah, she could. But it's one of those ones of which we want to be very judicious with what you choose. In this case, we choose specifically, but what is chosen by our ophthalmology colleagues, or those who might actually have some privileges to use some of the devices like MIGS, depending on the instance. But it's just one of those things of which, again, that's just a state by state thing, and not really germane to this course and to uveitis, but just because it's there, I just mentioned it. I tend to follow the patient on a stepladder approach. This is developed by Foster a number of years ago, and it's something of which I've employed, very much so as a religion in my practice, because I wanted to make sure that I follow these patients on depending on the amount of severity of the case. Now, do I do 1 day for every single case? Absolutely not. But I try to kind of follow this regimen, and there's obviously some tailoring to each individual patient as to how this looks. But it's one of the things of which I kind of like to keep this in the back of my mind as to like, am I going to see them the next day? Am I going to see them in 1 week, 2 weeks? Maybe it's 3 weeks. Who knows? 1 month, 3 months, and 6 months. That way, we don't lose them to follow up, and they all of a sudden develop, an inflammatory response in between, and they play it off like, no big deal. I'll take care of that when I want to, and then it becomes a larger scenario when they, when the proverbial crap hits the fan. So that's the thing of which to be aware of. And obviously, the comment down here is very, very important. Beware of steroid-induced glaucoma, pulmonary fibrosis, deafness, and acquired optic nerve atrophy. And that comes back to a certain extent the conversation regarding being judicious with the steroid use, and not just, obviously going for it, and just making sure that you kind of, you think through these cases.
Coop, I think
Mike,
we're getting
interestingly,
Go ahead, Joe.
go ahead, Greg. Go to Greg.
Just go to slide 55, because I think we have a Lisa. Let me know if that's the right slide. And Joe, please make your comment.
I can't remember what it was now. Oh yeah, your follow up is good. Sometimes people who don't have experience get nervous. I've always said that daily follow up of uveitis is like watching paint dry. There's 1,000 cells in the chamber today. Tomorrow there's 998 cells. So follow them, but don't follow them too closely.
Right. And the question?
There's no question. It was
Okay.
just, could you go back to the last
Okay.
slide? You were on slide 56 for a while, so I'm thinking it was 55. So
Got it.
I messaged her privately. I'll have her ask which slide, but go ahead and keep moving forward.
Got it. All right, so we're we're slowly moving forward here. We got to the conj and the cornea, and you can see these different types of nodules that you can expect to potentially see. We talked about KPs, interstitial keratitis with syphilis and Cogan syndrome, and you can see stromal edema and/or fibrosis in HSV. So again, to remind the audience, I'd say to you that the IOP portion of this conversation, it's one of those things of which reminder that IOP will go up in herpetic cases rather than go down. So this is not my scale. This is actually from the Sun Group, and they developed this is still to this day, obviously, what we tend to use for grading and what have you. So I put the gel in the 4+ is me. It's not what actually is in the scale was as the nomenclature, but to me, that's what it looks like when I see a 4+ cellular response. It's almost like you can see, little cells in a snow globe because there's so much inflammatory response, there's nowhere for it to go. So you can see a lot of these different, different presentations and variability to it. Obviously with flare, it's rather inflammatory. It's more longer term in response. And you can see the degree of scatter is from a scale of 0 to 4+, similar to the cell. And when you see that fibrinous response, it's rather egregious when it's laying all over the place, and you can see it in different areas, and we'll show you what it looks like to a certain extent in certain images. So keratotic precipitates to keep the ball moving forward. As I mentioned before, you might have thought, well, it's granulomatous. Well, it's non-granulomatous. It has to present this exact way. We'll look at that. I'll give you a call out here. CMV uveitis, cytomegalovirus, obviously associated with HIV, small gravitational inferior random distribution, not, a granulomatous, like mutton fat, thick response you might expect potentially based on the condition, the severity, and the consistency of the long-term nature of the condition. And then you get other things like, essentially sarcoidosis, there's this medium to large mutton fat like, lesions. So it varies quite a bit. So this is a nice little cheat sheet that I have actually in the office, had in the office to remind myself of what to suspect potentially given the presentation. So that's something of which to be aware of. And that's herpes simplex, obviously herpes zoster, keratotic uveitis. So, so next poll question. Then Dr. Tran had mentioned this in a while back, 10, 15 minutes ago. There's no right answer to this specifically, but it's always good to kind of see what people think about on this one.
Hey, Coop, way back, there was a question about, where does vancomycin fit into the treatment
of Lyme disease?
Do you have any comment on?
Yeah, it's usually used for more severe Lyme disease cases, ones of which you're not just seeing a Borrelia infection. You typically will see patients being used for when they have co-infections. The other instance where you might see vancomycin used is when you're going to get burnt out with doxy and some of the other antibiotics that are out there, and you want to kind of hedge towards a quote unquote stronger antibiotic that has a strong essentially strong broad spectrum of activity. So you can see it used in that instance as well, but it's not as common comparatively speaking, but it can be used.
I would also guess probably if there was an allergy to doxy of the tetracycline group that there might be an indication there. So
yeah, but it's and typically you check off and you do some of the other cephalosporin or something else first, more than likely, or an amoxicillin, such macrolide, all these different other molecules you could use before you hit vancomycin, considering the essentially the side effect profile. So. So this is kind of what I expected it to look like. And there's, like I said, there's no right answer specifically. There can be some instances I can tell you from my clinical experience where you might reach for it after the first event because you might suspect something really strongly and you want to go towards that. Or you have, something of which, classically we're taught in training to do it, after the second event. But quite frankly, I think in this day and age, the third one, which is what people mostly talked about, it's complicated to make a judgment call based on the presentation, is probably the best one at this point in time. If this is several years ago, I probably, may have said, choice B is probably the most popular one in a poll question like this. But now that we've kind of, using our judgment, I'm seeing more and more of this, and I tend to align with that. That it's not exactly as straightforward as one makes it out to be. So, as promised, here is the actual workup and what you can use, given in a particular case. Would you do everything that's on this screen? Absolutely not, more than likely. You probably would pick and choose what you're going to look for. And you're going to have your complete blood count, your ESR, which is your sedimentation rate, your C-reactive protein, your lysozyme, your serum creatinine. And that's obviously, as I called out here for the pediatric populations, for TINU specifically. On the rheumatology side, you have ANA, you have rheumatoid factor, you have ACE, we talked about that. P-ANCA and C-ANCA, that's for scleritis specifically. So if you had some suspicion that you had a case of, say, Wegener's granulomatosis, that's the instance of which you tend to kind of reach for this particular type of testing. And I put this question out there for what about an MRI? Well, it's a game time decision. You could utilize this technology to essentially, more or less decide if you have an X, Y, or Z. Like if for instance, you were thinking that you had let's kind of just throw it out there. You had say for a Lyme infection, or you had a neoplastic, disease that was running through the system, and you were trying to figure out, is it masquerading? Is it not? Is it a tumor? Is it not? I suppose you can kind of go that direction, but that's kind of a stretch. But I think it's more for cases like, as a for instance, multiple sclerosis. That could be something of which is, obviously we see inflammatory responses, we've seen optic neuritis, and that's something of which we can potentially use this type of technology to further, tease out further details as a differential, to be more specific. So serology, you have a whole litany of different types of tests. You have your quantiferin goal, which I mentioned before for TB, which I prefer over some of the older types of tests. And you obviously do a reflex chest X-ray for these individuals. And then you have obviously all the things that I mentioned right there. I did put on there for RPR, FT, ABS, plus VRDL, for venereal diseases, obviously for syphilis. You have to remind everybody which is the diagnostic one versus which is the monitoring one for in the serology realm. That's what you have right there. You could test for herpes. It's one of those ones of which you probably classically would do that on your own. If you really were just like, in it to win it and you want to know type 1 versus type 2, certainly you could do that if your heart desires, but I don't usually order that, but it is something of which for completeness sake, I talked about the tick-borne panel. Bartonella, great one to do if you have some suspicion specifically of cat scratch. You could also be thinking about not even just cat scratch, but also if you were, say, dog scratches for toxic cariosis, you could actually go in that direction too in testing. But it's again, it's to tailor it to what your history is and to the signals and to the symptoms, so that way you're not just ordering a litany of different things, because sometimes it almost you start to almost confuse yourself and get too much into the weeds given the particular cases. So that's what that looks like. You have immunology, you have all these different things you've seen before: HLA-B27, B51, A29. So there's a lot of different things there. Here is my cheat sheet for acute versus chronic conditions, just to kind of be on the up and up. These are some of the things we'll go over in a few minutes, but it's just one of the things that what you see. You have ARN, you have MUDs, you have toxoplasmosis, which we can really get into specifically, VKH, which we'll talk about, like I said, HLA-B27, trauma, and then on the chronic side, you have those smaller in cases like sarcoidosis, tuberculosis, serpiginous choroidopathy, and many others. So what does the patient demographics look like? And we're just getting into some some of the different areas of which is kind of bucket patients into. This is a good slide to kind of take a snapshot of if you have the ability to do so, on the screenshot. But it's nice to kind of just almost reorient ourselves and thinking about, like, I've talked about a lot of stuff, but where does it all sit in particular ages as far as demographics? And some of these will actually show up in variability amongst a bunch of them, but in the same breath, it's one of those ones of which it just grounds you in the discussion. So anterior uveitis, we see it frequently. We talked about this ad nauseum in the cases. We have both granulomatous and non-granulomatous. It could be a herpetic, it could be a CMV, it could be Ebola, it could be COVID. There's actually been a number of cases in literature that have been COVID related, or it could be non-infectious. Most of the cases tend to fall into this bucket, which you've talked about in the very beginning of this presentation in discussing where most patients tend to lie. So when we go forward here, from on the iris and anterior chamber, you can see again that Batman sign to a certain extent with the posterior synechiae, and then as I promised you, see a little bit of the flare, and you can see when you turn your slant a little bit obviously to an angle, and then you can see that reflection. You see that whitish kind of almost like a fibrinous-like response. This is a very mild case of it, but this is the inflammatory cells in the anterior chamber. This is one of my cases right here. So what's next? So we got the Busaka versus Kepi nodules. Now, there are aggregations of epithelial cells and mononuclear cells. We talked about this with Dahl Fuchs nodules for the sympathetic ophthalmia case before, but this one, an easy essentially mnemonic that you kind of, if you're not seeing this right in front of you, you have a book, handbook in front of you. When you see Busaka nodules, you're looking at the surface. The S stands for surface. When you have the Kepi nodules, that to you is a call sign. If you see them peripherally at the pupil's edge, that is your way to kind of remember in your brain which of these two you're actually looking at. Both are obviously typically, more the Busaka, more granulomatous. You can see on the Kepi nodules, they can be both non-granulomatous and granulomatous as far as presentation. What's not on here? We don't have leash nodules. Leash nodules of neurofibromatosis 1, that's pathognomonic for that condition, kind of a hallmark. Not a kind of, it actually is. And that's something of which to be aware of in those instances. Has a lot of other pathology that goes along with it, but just to be aware of it. Intermediate uveitis. We can see vitreous cells with the slit lamp. We can see obviously the pearls you see into the right. It's vitritis, it's pars planitis, and it's iridocyclitis. Now, I don't have a picture specifically of snowbags on this slide, but that's when those pearls will amalgamate, and then with gravitational forces, eventually over time, they will sink lower into the actual inferior portions of typically just more inferior to infero. I see it temporally a lot of times. We can see it infranasally as well, and that just happens because of the amount of time that particular avascular inflammatory response has been present. So, going from here, you can see, I wanted to blow it up a little bit so you can see a little more clarity. You can see those vitreous cells that are streaming throughout. And that's the thing of which, what I tend to have patients do, and my little trick of the trade is, if you're having trouble seeing cells, whether it be anterior, cell or vitreous cell, is you have the patient look up, look down, look left, look right, and then it's like shaking up a snow globe. You can start to see these cells undulating and flowing through the aqueous humor, in this case, the vitreous, so that way you can actually get better visualization. So it's a nice trick of the trade. I tend to use that if I have a question mark. But again, everyone has their own way of actually looking at these different types of findings. So here's more pictures of vitreous cells. You can see the snowbanking on this slide. You can see more snowbanks. You can see vitreous haze, which would be probably more in the avenue of candida infections, where you have, like, say, I don't know, fungal keratitis, or in this case, a fungal retinitis or panuveitis. So you can see lots of different things in this particular space. And obviously you can see the corneal scarring that can occur over time as the inflammatory response tends to kind of dissipate over in time itself. Posterior uveitis. So we have a whole host and litany of different conditions that can be associated with this. We've mentioned some of them already, but invariably we see a whole slew of them that run throughout that can be both infectious and non-infectious, or purely just inflammatory. So what are we looking at here? We're looking at, to your right, the rightmost one, we're looking at actually, that's the Candida albicans that kind of manifests itself. You can see these candle wax drippings, and you can see the macroaneurysm. In this case, you can see one up top at about, I would say about 9:30, 10 o'clock, and then one that's actually dissipated down below. So that's that case right there. The middle one is a syphilis case. You can see neuroretinitis, and you can see then, obviously then the macular star right there. That is like super classic. It could also, you may think of it, oh, just syphilis. Neuroretinitis has many different presentations, many different faces, including Lyme disease as well. In a later phase of it, you can see this exact same presentation. So just be wary of that, and not just classify as X and Y. There can be more than just the one or two or three or four different presentations. The leftmost one is toxoplasmosis. So that's the parasitic response, and it's burrowing through the actual retina, and it's essentially scarring the tissue because it can't find any nutritional value into it effort to punch through. It's kind of like its endpoint. So this is punctate interior and choroidopathy. You can see the punctate nature of this. I'm showing this to you in a few different ways so that you can appreciate it in a collage. And then obviously with the OCT, then down below, and then you have obviously your fundus autofluorescence and your FA. So you can see this. It's obviously, you can see that the hypofluorescence of these little lesions that you can see here, and then obviously you see the actual domes that are rather classic. Sorry about that. that are rather classic for this particular condition. So obviously, we're not really managing these cases in most instances. This is typically going to be seen by a retina specialist or a uveitis trained combination specialist. It just depends on their training and where you are locally speaking. But it depends on who you're working with. I typically refer that to a uveitis specialist, but obviously retina specialists probably can manage that as well if they have the appropriate training. In this case, we have serpiginous choroiditis, and you can see this classically. These are two FAs, and in both, essentially the early phase, which is B, and C is the later phase. You can see that there's more deeper pigmentation, so to speak, or it's not as lit up and fluorescing, in the earlier phase, and as far as the perfusion or lack thereof. But now you're seeing more of it actually occurring when you look at it actually in C. This one, again, it's another form that I figured, based on the fact that this is from like a multimodal imaging perspective for persistent placoid maculopathy. You're seeing these different presentations, lighting up the areas of which this is kind of the earlier phases of, in this photo, it's an older photo of OCTA, looking at these different slabs and what have you. So you can see these little plaque-like lesions, little bumps. Specifically, you can see the dropout and the extra signaling occurring, specifically in ENF. But you're also noticing it as far as that more deeper coloration, which is pathognomonic for this particular case. Panuveitis. Inflammation that's present in all segments of the uvea. It could be non-infectious, it could be infectious, and it's essentially the proverbial crap has hit the fan, and everything's inflamed to some degree or another. In a lot of these cases, it's rather difficult to manage them. It requires probably multiple collaborative care specialists to work on these cases. It's not just let's work with the uveitis retina specialist. It's probably work with a whole a group of different subspecialists to manage those particular cases, depending on the severity and presentation. So we want to make sure we manage that appropriately. So that is we have for all the different realms from front to back. And now we're on the treatments. So we have the topical ones, which we've talked about quite a bit. And you can actually use any one of these, again, depending on the type of uveitis you're experiencing in your chair. Why would you say like, oh, use antivirals? Well, if it's a herpetic in nature, you're going to use an antiviral. So if it's a lesion of which is bacterial in nature, you might obviously use an antibiotic. But obviously, as you get more deeper into the realm of what's out there, you have these types of things, which is intravitreal, injectable, and now suprachoroidal in as far as treatment choices. Xipere is a newer an entity into the market, still using triamcinolone, but it's using it through a particular device to actually deliver this particular dose for a patient who has, as Greg mentioned a while back now, patients who have macular edema. In this case, it's for indicated for the treatment of macular edema associated with uveitis. So you can use that type of agent. You can use obviously the other ones that are mentioned on here. You can use Iluvien, Ozurdex, Retisert, Utiq. The one you may not have heard of is Jackanibs, which we'll get into in a moment. That's becoming a little bit more common to be used amongst different specialists, and it's as I said, we'll get into in a moment as to what that really means. But it's another anti-inflammatory molecule or biologic we can actually employ to treat these cases to be steroid sparing, which you'll hear me say now for a bunch of times in succession, because we want to make sure that we're not using or overusing steroids, as was mentioned before. So orals are also part of this conversation. We can't leave those out. Any one of those could be used and then some. But obviously you see steroids that can be used, but once more, trying to be as steroid sparing as possible when the situation arises, to not overdose a patient and not continuously hit them with these these anti-inflammatory molecules. Doesn't mean we shouldn't use them. It just means that we try to kind of be thoughtful about how we employ them, given the case scenario and situation. You can use MTX in some of these cases effectively instead of having to use other molecules. So I mentioned Jackanibs, and here's what they are. They're Janus kinase inhibitors. If you've heard of tyrosine kinase inhibitors, TKIs for short, this is the other protein, kinase molecule that you can use. And this one, it's, when I was at Arvo, it was interesting. Poster after poster after poster was talking about JAK-inhibs and how they were employing them in these particular subset of cases, rather effectively actually. But it can be used obviously in clinical practice as well, just not as common. But it will become probably more and more common as time goes on, depending on the advancements with this with this particular molecule. You can obviously tap into other things than like voclosporin, tacrolimus, but again, there's no traction with some of these things because the side effect profile can maybe kind of force you to kind of think otherwise. Tocilizumab with MTX or methotrexate, that's another option for you. Small molecule pyrimidine inhibitors. Anti-VEGF is a possibility as well. And the other one that we have down here is photobiomodulation, which you can see one of the devices that's currently, that's not currently per se, but it's out there. And gavokizumab, which has failed in trials, but still find its way back in, as a potential molecule, of choice, for future thought. But it's, again, these MABs tend to kind of run their course, and then people move on to a newer clinical entity or chemical entity when during drug discovery from a pipeline perspective. So getting back to our cases, and we'll kind of move a little faster, I know for the sake of time, because we're hitting almost 10 o'clock hour. We got a 24-year-old Caucasian male presenting with a complaint of bilateral red eyes. He mentioned his eyes are painful, watery, and have excessively blurred vision. He's been experiencing symptoms for the past few months. He's held out due to a lack of insurance, and his systemic history was unremarkable at initial presentation. So for the sake of time, I'm going to move forward here and give you the history. So what happened here was this patient was seen by my colleague in the practice, and he could use a head scratcher. He's like, I can't really figure this out. And I want you to take a crack at this. I'll give you, he had blood work already done for, a customer, as he would call it, a customary uveitis blood work, workup. And it was just a laundry list. It was like almost like a cavity search as to what was going on there. So I, for consistency, I ordered some of the things along with the chest X-ray and stool sample, just to make sure I wasn't missing anything, because it seemed like everything was already done. He did mention that he lived in a basement apartment with some level of mold infestation, and he worked at a gas station. And the thing just to kind of, that I want you to be wary of is what I said here: a strong receding hairline. That's kind of like, he's, early, stage bald, or, male pattern baldness, but these silvery white tufts. And that's something of which is to kind of keep in your back of the mind as we go through this. So as I mentioned, we ordered the blood work. It was fine. It was, it came back, pretty much clean as a whistle, but yet we have 4+ cell. We have 2+ mutton fat KPs. We got multiple areas of PS. We got a pressure that's pretty normal, and a dilated fundus examination was unremarkable. You would think through a 20/40 vision, you would not be able to see, with 4+ cell, you would not be able to see 20/40, but he plowed through. He found a way. So what happens next? In this case, again, I'm using atropine, predacetate, and I also layered on top of that, I used generic Acular, because I really wanted to kind of hit him with as much anti-inflammatory control as I possibly could, considering the circumstances. He was, in this case, this one was seen daily based on the presentation, because I wanted to kind of watch him back to ensure success. Could you have seen him back in a couple of days? Yeah, you could have. But I kind of like to follow these cases where there is a little more up in the air than less in the air, while I was waiting for the blood work to come back, so that I can see what's going on. Then after the first day, I was like, all right, I'm going to see him back in a few weeks to see how things are going. But I wanted to kind of see what was actually occurring on day one, to see if I actually responded to therapy. So as you can see here, his visual acuity improved to 20/25. He did have a rare cell, so he actually responded rather nicely to the therapeutic regimen. But unfortunately, he was lost to follow-up, and a sister who I knew, who's a pharmacist locally in the area, she called me the next day and it's like, so so-and-so hit a mirror, or took the side of his side mirror off his car, and I'm a bit concerned. So what ended up happening is he comes back in now. Reminder: his vision when he first came in was 20/40. He improved to 20/25, give or take. Now he comes in with 2200 vision. And the pressure that was 17 is now 40 and 54. So what was he doing? He was taking his steroids daily, So this is the case of which we cautioned about before, about like, using steroids judiciously, using them, and when to use them and how to use them, et cetera, et cetera. And he was saying, well, that was how I managed my redness and intermittent pain. I needed something and I couldn't afford you. So I was going to do this. So there was no dendrites present. So obviously I'm trying to rule out any HSV or herpetic infection, but he had 2+ month fat KPs again. Now, the macula, this is a remarkable one. The macula, it had CME, let's just say like no one else. And I'll show you the picture in a second. He had snowballs and early snowbagging because he hasn't been around for 9+ months. Could he have had, an acquired optic neuropathy? Not in this case, but it's something just to be mindful of. So what did he look like? Well, that's what it looked like. It was like a tent. So, in this case, the thickness was off the charts. When you look at, obviously your normative range, you're not thinking what this is, which is about 700 microns. It was ridiculous. It was really elevated. Obviously, you can see all the layers separating and pulling off, and that's why his vision was so ridiculously, low, so to speak. But what ended up happening next is obviously, to get that pressure down, I gave him everything but the kitchen sink in the office to get him to at least a respectable level, and then I sent him with topical medication thereafter. I did call retina, begged and pleaded to actually get him in there, to actually get some Kenalog injections, and then his vision obviously improved. You can see there with some stabilization of the CME that the retina, for all intents purposes, the fluid that you saw in this image right here, was significantly reduced with these injections, and the tent-like appearance became more regular. Was it perfect? No, but you were able to see a foveal pit, which was not present before in that particular case. So he came back religiously for a little bit, and then he disappeared again, like a lot of these patients tend to do. So what would you do? What would you say in this case? How comfortable are you co-managing these uveitis cases with a specialist?
Hey, Coop,
Yeah,
we're
Coop, go
really
ahead
right
and,
about 10 o'clock.
Yeah.
We're right about 10 o'clock. So I think we got to get some parting comments. You said you mentioned earlier you did not have images of snow banks during your presentation. I sent you some copies of
Yeah, there were
patients that I've
snowbanks.
had.
Yeah, there's snowbanks in there.
Okay.
It came up a little bit later on from that first initial image.
Okay.
So to complete this case, so people can know what actually happened, this is a case of VKH, and the only thing that actually was identified in the lab work, which is an HLA DR4, which is you normally wouldn't order that, but in this case came back positive, and it is something of which can be identified with VKH, and so we suspect in this instance that he had actually VKH. So everyone can look at the slides. He doesn't fit the actual typical presentation of it. But it's something of which based on his presentation itself, if you look at the case, the slides themselves for this one, you'll see that it kind of fits relatively into these different areas for stage 1 through stage 4. So that is really about it. So in this case, we used steroids that were but we kind of had to obviously shift our gears to other therapies like MTX, and then we went from there. So there we go.
Perfect.
Thanks.
If you can let me share the screen, that would be great.
Yep.
Well, Coop, you certainly matched up with the crash course of uveitis here. This will end the CE part. Thanks everyone for attending. And Coop, you did a great job. I'm sure your virtual round of applause will be coming in here shortly.
Thank you, everybody, for your time. Really appreciate it.
Thank you, Cooper. It's a great, very, very in-depth discussion. He went really so very well over a lot of these topics. I think everybody's going to really appreciate it.
My pleasure.
And everybody's giving me a round of applause.